Colonoscopy scenarios. Is an open, different case. Do you want to do that now, or should we do that at some stage?
I was thinking we've had lectures now.
Yeah.
We just have a 5-minute discussion. Go on to the video.
Yeah.
As planned.
Yes. Okay.
Okay. Then there's principles of colonoscopy and scope handling after that. I was thinking just before we finish the hands-on, we do that just at the end. Because we'll almost be dead by then, and so it will be good to sort of wake everybody up, bring them into discussion.
Then we can do the discussion at a later stage.
Are there any questions that you want to ask? Please do. Not giving.
Or shall we take a bit of a rest before the video? I think
we're just discussing.
Okay,
5-10 minutes discussion before the video. We
any open questions?
I was just telling them that, I don't give kins quite often before midazolam. I'm guilty of that. Theoretically,
not such a big crime, but
theoretically, I'm not too sure. Practically, how much difference do you actually see? I've actually done that. When we first did that, we started giving midazolam, gave a minute, and then gave. There was no change in my practice of using the drugs. We did that in about 10 or 15 cases, and then I said, quite often I'm not sure whether I'm going to use kins or not. So I just give midazolam first, and sometimes kins is given first, sometimes midazolam. So I'm guilty of that. Practically, it hasn't affected my practice, but as I said, if somebody has written it, he's obviously got much more information as well as knowledge than I have. So if we find something out, we should try and practice it. There is no harm, you just need to give one injection before.
Other than that, it's best practice, that's all it is.
I think a lot of these things which are best practice do not have grade 1A evidence, like randomized control trial behind them. It is just an expert opinion or recommendation by a specialist society, which is grade 2 or 3 evidence.
We want to hear something from you, then speak. Also interact. While we have 5 minutes, let me have introduction from Shamim Qureshi. I'll introduce you. He's a buddy of mine. We were together. He's heading surgical, I don't know which one, JPMC. We were class fellows. He's very, very keen in colorectal work. Organizes this fantastic colorectal workshop and does lots of good things. I've always been telling him he doesn't know how to do colonoscopy. He needs to come and learn.
That's a pity, but I have to learn from him.
But I'll tell you, but he said, I will never learn from you. No, he said, I will never learn from you unless you have somebody good. So I told him, I said, I've got some of the best, so you come and sit down with us. So he's just here, part of an extended faculty to give us a feedback. I'm just joking, he's doing a lot of good work. Sharia is
Kingpin.
I've already told you, is Sajda and Sharia are the pillars here. They do all the work and we get all the credit. He is the assistant professor here and does surgery as well as endoscopy. Both Sajda and Sharia are very good in all endoscopic procedures that are done in IU. Right, Doctor, you start.
I'm Dr. Riaz from Fatimah Hospital, Lahore. I'm doing SSS Part 2 training gastroenterology, and I'm in 3rd year of my training.
And how many colonoscopies have you done?
I will be 25.
So you've done some, and you're with Arif?
I'm with Professor Arif Amir Nawaz.
Okay, great.
My name is Dr. Saeed Ahmed. I'm in Surgical Unit 1, Civil Hospital, Karachi. I have been trained Surgical Unit 4 by Dr. Saida and Dr. Sharia, and Dr. GI endoscopy and colonoscopy. Now I am doing colonoscopies in Surgical Unit 1. We have the colonoscope, and I have done 22 colonoscopies till now.
Very good. Also, please mention who's on hands-on.
I'm hands-on.
Hands-on.
I'm hands-on.
You're hands-on?
Yeah.
Okay, good.
I'm Dr. Fawzia Qasim and I'm working as physician at Balika Hospital. So So, and I am a live candidate. I'm just started observing colonoscopies and endoscopies at PMRC.
Oh, so you're observing as Waqaf?
Yes.
Okay, and you're here as an observer?
Yes.
Okay, good.
Assalamu alaikum. I am Dr. Rizwan Sultan, fourth year resident general surgery at Aga Khan Hospital. I am here at an rotation from our department for endoscopies, to learn endoscopies, and I have no experience of endoscopies before.
Okay, good. So you're just an observer here?
Assalamu alaikum. My name is Dr. Fahad Tariq. I have just been selected as an assistant professor here. I work in surgical unit 4, and I've been working in this unit for some time now. And I'm here on a hands-on course.
How many colons have you done for?
Sir, a few. I'm still learning.
There's nobody there, so we start this.
I'm Dr. Farzana, Associate Professor, Surgical Unit 4, and I am here as an observer for colonoscopy workshop.
Dr. Farzana is from our unit. She's the Associate Professor here in Surgical 4. And,
my name is Dr. Kashif Razak, sir. I have come from Pindi. I am doing my second FCPS in gastroenterology, and this is my second year, and I have done 50 colonoscopies, and I am for hands-on.
Ashif, you are in which unit, sorry?
Sir, Military Hospital, Pindi.
Pindi. And who is there with you nowadays?
Nowadays,
Keep changing every
sir, Shahid Raza is there.
Shahid.
Sir.
Shahid, the one who's in Sheikh Zayed?
Yes, sir.
He is now in
Pindi.
Okay. But Rasif is also a regular with us now.
Assalamu alaikum. I am Dr. Javed. I am working as a chair professor in surgical unit 5. I am an observer.
I am Dr. Dilip from JPMC Ward 2. I am working as a senior registrar in Ward 2. And I am doing colonoscopies and upper GI endoscopy.
Here in Shamim Saab's ward, right?
Yes.
He is regularly doing it for the last 3 years, 4 years.
So he's an observer.
He there just to polish him.
My name is Zishan Ali. I am working in JPMC Ward 7 with Professor S. Munir, and I am doing regularly there the endoscopies. I have done few colonoscopies, 15 colonoscopies myself.
You're hands-on.
Hands-on.
You've been Munir sir.
Yes, I am a hands-on with Professor Munir.
I am Dr. Yaqub Jahan, pediatric surgeon, and working as a senior star in the Department of Pediatric Surgery at Civil Hospital. And for colonoscopy in children, we just observe, and I have no prior experience.
So you're just here as an observer. Okay, just a couple of things for observers. If you tell Sajda, good Lord, Sajda. I'll have to share this last thing with everybody. For those who are observers here, if they tell Sajda now, by the end of the course, that they would want to be hands-on in the next course, which will be sometime October, November this year, then they would be given priority over others. Okay, but you have to do it before the end of the course. After the course, you go into the regular thing, because it becomes very difficult for us to keep track of who is really interested and not really interested, because it's 6 months. So people may change their mind, and then we have slots which we have to decide.
Sir, what's the rationale has been such a limited number of hands-on?
Okay, I'm coming.
Yeah, because there are three
okay, I'll tell you what.
Here,
because
and people are coming and they are just observing. We're going back.
We
so
will ask.
Give them a minimum chance.
Okay, let me ask this question from you, Doctor. You did our ERCP course, hands-on. Just tell us what was different by having less numbers. What was your feeling? Rather than me telling you what he did our hands-on.
By having less numbers, sir, I was able to perform ERCP procedures with every consultant. Once with Dr. Bagar, once with Dr. Saad, and the doctor. Variety of experience, and it was really good teaching experience.
See, we want to give each candidate at least 3 colons before the end of the course. So they will end up doing 3 colons. They will hopefully reach CECUM with, if necessary, some assistance during the course. Other than that, they will have a lot of hands-on experience, an explanation of loops, which we were trying to tell you about what happens when you fill in air. Concepts that that you may have heard, but you probably don't understand that well on dummies and also in live patients. We have scope guide, we'll have fluoro while we're doing, so we can actually show you what we are theoretically telling you practically. So the idea here is to have less numbers so that each one, we can focus on them, we can train them, they get enough hands-on experience, at least 3 or 4 cases each, so that when they go back to practice in your unit, they have learned something. If we can have 45 people here and show them colon, it will have no effect. This is
the limit of 45 and 5.
No, but you see the thing,
I think
how many
I'll explain to you. This type of course in worldwide is practiced only in 7 centers. 6 or 7 in UK.
6 in UK.
Yeah, 6 in UK, and Karachi is the 7th.
7 from May.
Yeah, 7th from May. Yeah, because you are starting another one. So basically, Karachi is the 8th center in the world which hosts this type of course. In UK it's 7, it will be 7 now. For ERCP in UK there are only 2 centers who have this hands-on course. Nowhere else in the world such a course is held. Karachi is the 3rd center in the whole world hosting ERCP hands-on. The simple concept I would relate to you is once I took my daughter, from school, she had to go with her, follow one of her parents on a day of work, So the choice was either to follow her mother in kitchen or follow me in the hospital. And I took her for an endoscopy session, and then we had an ERCP session. And she said to me, Baba, you make such a big fuss about ERCP and things. It is such a simple procedure, you went in, you took out a stone, and that was it. And I said, okay, yeah, I said, it is a bit. And then I gave the next procedure to my registrar, and he was doing it. And then she said, now I know why you make such a big fuss about it. Because if SARS performs an ERCP here, people will think it's a piece of cake, and they will get the wrong message. If you give the ERCP scope to them and ask them to perform it, then it's a different thing altogether. So hands-on, you only, like in UK when we do hands-on courses, the maximum number is 4, and that's it. There are no observers at all. Observer here is an innovation. यहाँ पे बिद्दत है. So this is, but it's a good biddat. So we are doing it.
I'll tell you, the thing is, if you have 10 patients, 10 people here, 10 candidates, okay? We have 20 colonoscopies. We'll be able to give 2 each. If we have 20, we'll give 1. If we have 5, we give 4 colonoscopies. That's a lot, because first colonoscopy you have no idea. Half the time you're not understanding. Second time you start at least understanding the left colon. You start understanding the concepts of loop. So the whole idea is to give you hands-on conceptual learning. If you go with that, then you have the foundation. You're not going to become a very good colonoscopist day 4th of the course. You will not. But what will happen is over the next 6 months, when you've done about 100, you would know what not to do. I think that is very, very important if you're taught. I didn't get this kind of structured training or course. I wish I had. But fortunately, I was with people who were good in colonoscopy, so there were things that I learned from them. And if you are lucky to have someone like that, then you would probably have it, but it just reinforces some of the concepts. And that's the reason why we keep the numbers low. Also because we also want to make sure that, we have interaction. An observer is something that we started because of this limitation. Or even observers, I would love to come as an observer in a course like this. I am an observer. So I'm actually seeing, and there's a lot of learning as an observer.
The other thing which we would strongly urge you to do is to maintain some sort of contact with us, email or whatever, that we have a constant,
Now that's something that we failed in doing in our first course.
Yes.
I'll be honest with you. And so far in ERC,
in touch with me. There's 2 people who've
kept in touch with you.
So it's always a good idea.
I've had ERCP people write to me saying, I am happy, I did my case, and I was really, I enjoyed doing it, I understood whatever, And similarly somebody else wrote, but not regularly. But I think that's something we would expect. If you can give us an email, let's say you've done 20 and you do another 20, you achieve 50 ka figure, and you write saying I've done another 25 cases, and my intubation time is this. In my private sector now, we are actually monitoring my intubation time, my extubation time, my procedure time, my sedation time. Everything is now being monitored for my own, satisfaction and all, rather than for anybody else. But I think it's important. I equate colonoscopy, and I do endoscopic procedures, almost all of it. And to me, the most difficult procedure that I do is colonoscopy, even today. And the reason why I say that is that this is one procedure which can be made difficult by me. I have to struggle making an ERCP difficult myself. I really can't make it difficult. It is either difficult because there is a problem, but I can't make it difficult. But colonoscopy, I can make it very difficult myself. By creating a difficult loop, by not following the principles that I've learned, I'll make it very difficult for myself and for my patient. I equate it to playing golf. When you're doing colonoscopy, you want to reach terminal ileum safely in reasonable time, pain-free or minimum pain, minimum sedation, and excellent result. Now you have to put all these parameters and you're actually playing it every time. Because I can't achieve it every time. Every time I'm doing colonoscopy, I can't reach terminal ileum in 3 minutes or 4 minutes. Okay, it sometimes takes longer. Every time it's not pain-free. So every time I don't do it, I usually tell myself I'm doing something wrong. And it's usually the last case of my list. When I'm really, really upset, pissed off, I want to go. And then somebody will put another case on my list. So there's learning from, apne aap se you can learn yourself. And try and make sure that you're reaching terminal ileum, you're reaching there without pain, safely, like Vakar said, minimal sedation. So, abhi aapki sedation, for example, you're giving 5-5, no problem. After the course, try and bring it down to 3-3, then gradually take it down. Don't just be, as I said, they can do colonoscopies without sedation. They're very good. This is what they do. Their numbers are huge. We can't maybe be like that, but at least we can be as close to them as possible, or as safe for our patients as possible.
I think
sorry,
terminal ileum is a practice that you said that you do each year regularly. So supposing you do a colonoscopy and you reach the cecum in a pretty decent time, and but you're finding it difficult to reach the terminal ileum. So how much time you should suggest? And if the terminal ileum not per se as for indicated, there is no other indication other than the practice that we are following for reaching the terminal ileum. So how much time shall we spend to reach the terminal ileum?
Paul, 3 attempts.
Sorry?
3 attempts.
3 attempts.
Because you shouldn't make his life a misery just because you want to practice.
But I want to hear your views and I will just share mine.
I mean, if there's an indication, definite indication, and you can't get there, get somebody more experienced to do it for you, right? I mean, if there's another colleague in the department who can do it for you. Because, number one, I mean, yes, if for your own practice, for your own improvement, if you use 2 or 3 attempts to get in, fine. If not, the patient should not be put through unnecessary distress.
In the UK, what normally happens is that if you were with me, I'd be in the room all the time while you're doing the procedure. I don't know how you operate, but that is a guideline that I stick to. If you've not been signed off yet, and you've done 300, 400 procedures, I'll still be there and while you do it. Until you've actually been signed off and accredited. I've had guys who've done 1,000 procedures and they've never been signed off, and I will still sit in while they're doing their procedure. 3 attempts is what I give you to get anything before I start to interject. I'll be interjecting anyway because I can't shut up. That's the most important thing you need to know. Going back to what you're saying about the size of this course, the most important thing about the numbers is approachability. And what you've got is 2 guys who you can go to. If you've got large numbers, there's a lot of people in, you haven't got time then to deal with the people that are on the course. So the small numbers, you still got access to the faculty straight away. You can ask questions at any point in time. You can stop, because the biggest and most important thing is there's a mannequin, there are live cases, there's going to be things going on. Ask the faculty. It's not just the people sat here. You're looking at Saturdays, Sharia, ask away. These people know an awful lot. Our chap on the front row knows an awful lot, even though he doesn't say he does. The thing is that a resource, at the moment you're rich in resources. You've got 1, 2, 3, 4, 5, 6 very strong resources in this room alone. And that's a well that you can dip into. If we go back and you want people to upset you, we can easily upset you. But the idea about this course is not to upset you, it's to encourage you. Don't get focused on numbers. A lot of you in here are focusing on numbers. The idea of this is to do it well. If you walk away and you've done one procedure really, really well and you can reflect upon it, and that procedure then sets you up as a gold standard for what you want to achieve later on in your life, and that's grand. The fact is you may have done the other two not as well, but as long as you've done one to a gold standard and a standard that you actually walk away and say, I did that one really well, I'd like to emulate that for every procedure that I do, then you've got something to work to and attain. And what this course gives you, and the faculty hopefully give you, is something to strive to and achieve. Watching people like these guys doing the procedures gives you nothing. You don't see anything. And so you watching it on the screen, you don't see the little bits that they do. He does things and he didn't know he was doing them. And it become apparent on the last course he did it. And then when he went away, he said, I am doing them, but I didn't realise I was doing them. The thing is that we use an awful lot. But the biggest and most important thing is, ladies are very, disadvantage is, for us chaps it's easy to colonoscope, because as we get older we get bigger. And when we get bigger it becomes easier to do. These guys are growing into their positions.
Spending a few more courses.
The sumptuous dinners,
But the thing is enjoy yourself. The course is about enjoying yourself. If you don't feel that you can come and ask us a question, that's sad. It's a it's one of the few opportunities you're going to have in your career where you can walk up and you can say, Paul, what did you mean by that? What was that about? You can ask straight out. It doesn't matter. Don't be embarrassed by any question, because any question you ask isn't a stupid question. That's a big thing.
You learn more from the most stupid questions than you learn from the most smart questions. The most smart questions are thought about questions. You ask because you want to ask questions that, generally speaking, you want to impress the person by what you're asking. The silly questions, you know the person is not going to be impressed, but the ones that are most silly are the ones that give you most information and learning. I think one important aspect, while we're waiting for the video to be sorted out, one important thing is about doing courses is to see someone, to see people who are very good at doing something, do them, and to know that there is that much distance that we have to travel before we become, or we should never become complacent. We should always learn. There is always learning. It's a dynamic medicine as a whole. But I think it's important to know that, well, I'm good, but good God, that's very good. And that's where I want to be. And how do you reach that level if you have the right condition?
Could I just ask, going back to what Saz was saying, if I was to point to someone and say, what is your main learning objective? What is it you want to be here for? And then what was to say to you now? What is the main reason? What's brought you here for the course?
I do some mistakes of looking.
Okay, so I'd stop you, and you've used one word that I would pick on, and I say mistakes. What do you mean by mistakes? Is there a right way or wrong way, or is it that? What? So I'd be going back and asking you. You're saying you've used the word. Why did you use mistake? Is that a mistake? Whatever you do, it can be focused upon. Now, you'll see from the scope guide that we will still form loops. But going back to what we were saying earlier on, is a lot of the time we'll see a lot of people putting a lot of scope in and causing pain. The fact is you can put a lot of scope in and you cause a little less pain than what somebody else does, because the speed, the pace that you put the scope in reflects what you do. So sometimes we do things that you would normally do in your practice. Is that a mistake? It's only because we've got the fancy equipment here so that we can highlight things. So the reason why I focus on what you were saying, mistake, there is no right and wrong here. On the course, it's not about being right, it's not about being wrong. Because first of all, let's take away, it's not about telling you off, it's not about saying that's poor, that's good. What it is, it's about trying to get you to look at something in a different way and be more positive about it. So if we look at something as a mistake, already we put it ourselves on the back foot. So there's no mistake, it is just that something I might have been able to do other things slightly better. So it's a state of mind. And a lot of these courses are about this hands-on practical. It's about trying to get you to think of options and the state of mind to be able to perform to
I think one of the mention Dr. Khan made about comparing it to golf is very appropriate. Because I was playing golf in Peshawar, and I'm pretty often at it. And the caddy who was with me, they are very good normally. So he said to me in Pashto that Dr. Sahab, that it's ये एक मतलब प्यार का खेल है, जोर का नहीं है. Because in golf, if you observe, if you try to hit with all your might, you make a mess of it. So if you use your correct swing, your correct technique, it comes out beautifully, and you can hit long distances. And I've seen 17, 18-year-olds hit the ball much further than the most well-built men, and it's all due to technique. So the same thing applies here as well. It's all your technique.
So now what we'll do is, in between, जब भी बीच में कुछ पूछना हो, you can ask questions. Stop us and ask questions. Please be informed. I have not had anybody ask me questions. It's not working. So we'll now start with the video. That's from, am I right, from Denmark?
Denmark,
Denmark. Paul, why don't we have a video made?
Well, I would actually think that would be the better thing to do, because this bit is good, but I've seen this so many times.
I know,
and if you watch the course, what I'd like you to do when you watch these guys, there's a video library, Experts in Action. Please look at that.
Nobody
because I laugh at it.
Yes. Nobody does it properly.
I'm going to ask my friend there to try and sort this thing out.
So we'll have a quick look at this video. There will be things different from this video that you will be seeing at the course, but then again, like Paul said, there are more than one ways of doing the same thing. As long as you achieve the objective, that's what's important, and the goals are there in front of you. What we want to do is, after the course, please tell us whether you, the forms that would be given to you are very important. Give us a feedback on not only whether this course was useful, but also what did you learn? What was it that, because all of you are doing. Okay, so we need to know whether we made a difference in what you're doing or not. Because if we don't, then obviously we haven't achieved anything. So be honest. Don't worry. When you say you don't think it's worthwhile, just say. So that's the only way we will learn. So we'll have a video followed by principles of colonoscopy and scope handling. I think that is a very Paul would be doing that, and then we can have a working lunch if we are running late. If not, then we'll take a little break for a lunch, but it will be half an hour. We'll try and combine that with prayers, so that immediately after prayers we are here. We'll delay the lunch a little bit, and then we'll just go on hands-on. The dummy we have is, I can tell you, is state-of-art. It's the one that's being used in UK. So everything that we are using here in this course is what is being used in UK for courses. We haven't compromised